As a brief disclaimer, this video focuses on the ethics of genome editing in somatic cells, not germ cells. The SCGE program does not support any research activities on genome editing in germ cells.
So could you start by telling us your name, your institution, and your role?
I'm Arthur Derse. I'm director of the Center for Bioethics and Medical Humanities at the Medical College of Wisconsin and professor of bioethics and emergency medicine.
Great. And then what's your role within the SCGE Consortium?
So I'm part of a team that provides the consortium with perspective on the ethical, legal, and social implications of issues that arise when translating basic research into the clinical realm.
And then now we'll start getting into the questions. So what do you see as the most important ethical issues in somatic cell genome editing in humans?
Well, the most important ethical issue that I see is the ethical issue that arises from the excitement about new discoveries, being able to use genomic editing to ameliorate or, in some cases, to cure diseases with a genetic basis. And that excitement overtaking our attention to important issues of safety and informed consent for participants in the research. And I think the case and the lessons of the death of Jesse Gelsinger, who was a young man who died during genomic implementation of research. And the issue was, did the participant, Jesse Gelsinger, and his family really understand the risks that were attendant to this particular aspect of viral vector attempts to ameliorate genetic basis for disease? Did they really understand that? And I think we learned lessons from that. But with the exciting advent of CRISPR technologies and other technologies as well, there's this urge and wish on the part of people suffering from diseases with a genetic basis to, do something to be able to ameliorate these. And in fact, that pressure, I think, is an important one, but it needs to be balanced by our concentrating as well on the safety and attention to the risks and attention to understanding of the risks for participant in the research.
And then so what should informed consent look like for human participants that are participating in a somatic cell genome editing research trial?
Yeah, so first off is informed consent in research is a lot like informed consent in medical therapy, except the most important basic understanding for the research participant is that even though there may be findings that will help and there's the possibility of benefit, research is not, in fact, concentrating purely on the benefit of the subject or the person. And so that misconception about what research really is something that's very important to delineate for a research subject participant. They might benefit, but the focus is in learning about this particular intervention. So that's the first, I think, most important piece. And then, of course, the risks of the research. What am I as a research participant assuming as a risk, which might include serious injury or perhaps death. But of course, the benefits, both benefits that might accrue to me as a result of this intervention, and also the benefits to medical knowledge and society as a whole are ones that should be understood. And then are there other alternative treatments for this that would forego my wanting to participate in a trial on genomic editing? And for many of these diseases, there are not great alternatives out there, but at least noting those and noting what would happen if the participant does not engage as a subject in the research. Also, above and beyond the usual informed consent in the therapeutic milieu, there are issues about, well, what will happen if I am injured by this research? What kind of treatments are available? What will the cost be? How will that be addressed? Those are really important to understand in a research trial. And then the usual informed consent requirements of information that's taken in, understood against the person's internal values about what they consider important, and then communicating that consent. And then finally, the consent needs to be voluntary. And many people who want to benefit from this, of course, are entering it voluntarily, but they also need to have that understanding and still be voluntarily willing to participate in the research.
Great, thank you. And then you touched on this a little bit, but for clinical trials of novel gene therapies, the risks and benefits may not be well understood, especially in the long term. So how does this impact informed consent?
Excellent question, because in many of these situations, we don't have data of the long-term effects. And even though if the FDA is regulating this, they are interested in long-term follow-up of the subjects of these trials, we don't know, and we have to say that we actually don't know the long-term effects, and we are going to be paying attention to them, and we are going to be following up on them. But this is where we just have to be honest, because many of these genomic therapies in trial are new, novel, and we don't know it. So I think that's an important aspect, is as opposed to the therapeutic milieu, where we may have a lot of data over the years about the outcomes. Here's one where we have to be, honest and show our humility in saying, we don't know, and we're going to be following you through the years to be able to find out those long-term effects.
Great, thank you. Sometimes parents or guardians have to make informed consent decisions for children who cannot make the decision themselves. So how can researchers find a balance between protecting the children and the promise of providing a potentially life-saving treatment?
That is a challenge. And the reason it is a challenge right now is that the federal regulations require that for children to be enrolled in a therapeutic trial, either the risks have to be minimal, or if they're greater than minimal risk, and gene therapy trials are, then they have to hold out the prospect of direct benefit to the participant, to the child. And that judgment is one that both the researchers need to make and parents or guardians need to make for their child with the disease. So that's a risk-benefit ratio, because, of course, as we talked about before, serious injury or perhaps even death is an outcome, and yet many genetically based diseases manifest in children, and children have an entire lifetime that's often shortened, in which they're going to be subject to the burdens of the disease. And so parents very much want their children to be able to benefit from that. And obviously, if they're in late adolescence, then the child still, him or herself, needs to be part of the discussion for assent for the research. But it is true that, on the one hand, the federal regulations are there to protect children, and on the other hand, genetic diseases are often manifest early in childhood and really do affect children. And in fact, there was a recent trial where CRISPR-based gene editing was found to be safe and largely effective in addressing a form of inherited blindness in a group of patients that also included children. And so that was wonderful. That was great to hear. We don't know that there have been any serious sequelae from that, but we understand how adults can certainly agree to that. And for parents of children, we understand why the risks and benefits of participating in the research, especially with the direct benefit that would ameliorate inherited blindness, would be something that parents might say, this is something that we want our child to be in a trial for, and hopefully to benefit from the implementation of the therapy.
Great, thank you for answering those questions on informed consent. So we'll switch topics a little bit now. For funding allocations and research priority for genetic diseases, what role should ethical considerations play?
This is a really important question because, first of all, there have been studies that have looked at prevalence of disease and the research that attends to the prevalence. And as you can guess, more prevalent diseases generally have more research funding applied to them from at least federal sources. And of course, if there are private entities that wish to invest in this, they're also interested in having funding of potential new therapies that would then, bring in some funding as a result of a larger population. And this, unfortunately, pays less attention to diseases that are rare, diseases for those who are underrepresented in clinical trials for various reasons, and for those that are in an undiagnosed disease that might or might not have a genetic basis for it, and it's less common. Those folks might not have people advocating for research using those individuals. So the thing about research is it's both an opportunity for these populations to have their disease addressed, and yet at the same time, it may also be a group that, for various reasons, are less inclined to participate in research, may not have as much of an impetus to be involved in it. And again, there are financial reasons why funders might say, we don't want to invest in this. So I do think that one of the important thrusts in the SCGE and in genomic research has been advocating for those who don't have access to these clinical trials. So again, it's a balance because these clinical trials do have risks. And so it is not an unalloyed good to be able to participate. And yet, without participation, those diseases that those individuals have won't be addressed. So I do think ethics has an important role to play, both for federally funded research and their priorities, and also for privately funded research.
And then for approved gene therapies, what are the challenges about cost, insurance coverage, and access to treatments?
These are really challenging because we're very excited that a gene therapy for sickle cell disease has been successful and has become approved by the FDA. But the problem is the cost of that intervention, which is, I would say, for an emergency physician who has treated patients with sickle cell over the years, nothing short of miraculous. I mean, this is incredible in being able to really address sickle cell disease at the genetic level in a somatic cell. Again, we're talking about somatic cells, not germline therapy. But this is really wonderful. It's exciting and extremely costly. And how will we pay for this apparently safe and very effective treatment for a population that will definitely benefit from it? This is going to cost, and insurance may or may not cover the cost of this, and federal funding for Medicaid may or may not cover the full cost of this. And how do we get individuals in the population who need this therapy now in the therapeutic phase of this gene therapy development? And one is advocacy, no question about that. Two is, I think, ethical aspects of just allocation of resources, because over a lifetime, many of these patients have very expensive costs of care and treatment for the sequelae of the disease. So there is a really good argument for doing the intervention as early as possible. But this is one where ethics and I think advocacy groups have a very strong role to play in making sure that once we have the benefits of this wonderful treatment, and again, early days, we may find out that long-term there are things that we should be paying attention to, but right now, it seems nothing short of miraculous.
Great, thank you for that. And then now to wrap up this conversation, is there anything else that you would like to say about ethics in somatic cell genome editing more broadly?
I would, because I do think there are issues that are really important that the whole genomic revolution has brought forward. And they are ones where we have new understandings of what human disease and human health is. Specifically, we're redefining the concept of disease. In the old days, diseases wouldn't be diagnosed until they were manifest. We couldn't look at the human genome and see that there were latent diseases that would develop over time that would end up causing problems later in life. So disease is no longer having the disease, but if you have a genetic predisposition or with autosomal dominant genes, a extremely high likelihood of inheriting that disease at a later stage in life. This is now a new concept of disease. Nothing looks wrong with a person. They don't feel ill, but they have this. And so that's one aspect. The next aspect about our ideas about health and disease are, individuals who have conditions that might be seen as a disability might also be ones that do not want that disease cured. And, deafness is a classic example of one in which the deaf community may or may not want to be able to access some type of a genetic treatment to be able to prevent or ameliorate those that are genetically induced. Another aspect is enhancement, and that is as we have these wonderful opportunities to address disease, do we now have an opportunity to be able to enhance certain aspects of human intelligence? And this is now a new ethical issue about, is enhancement something that we should be trying to advance? And again, I think the SCGE is generally looking at the horrible diseases that children and adults are subject to and trying to address that. But this also raises question for the long term, and even, the aspect of human identity and biodiversity. So there are a number of things that are implied. And there was a novel written in the 1920s by someone named Aldous Huxley called Brave New World, in which the phrase was one that was taken from Shakespeare, from The Tempest, where this young woman, Miranda, who's been, stranded on a desert island with her father, comes across other human beings and go, oh, what a brave new world that has such creatures in it. Aldous Huxley turned it around and looked at a world where we were defined by our genetic makeup, and humans were conceived in laboratories, and really a more pessimistic view of where we can go. And so I think the genomic revolution is one that has a number of paths that it can go forward. And I do think that we will need to keep our eyes on the good, the benefit, to be able to allow human beings to flourish at the same time that we try to ameliorate and to repair and to cure, if we can, those diseases that have a genetic basis. Thank you very much for interviewing me. So glad to be able to give some thoughts on this. All right. Bye-bye.
Bye.